Welcome back. Today we're focusing on nipple areolar complex reconstruction. It's often that final touch, really crucial for a natural result after breast surgery.
Absolutely. It makes a huge difference to how patients feel, their body image, their overall satisfaction. It's more than just aesthetics.
Definitely. So let's dive into the planning. Timing seems key. When exactly should we be aiming to do this?
Well, it really hinges on the type of reconstruction they've had and, any other treatments. Generally, you want a stable breast mound.
Okay, so what does that mean practically?
It means waiting, typically around 3 months after an autologous reconstruction, or if it's implant-based, after that second stage is complete, give things time to settle.
Right, let it stabilize. And what about anesthesia and sort of managing patient expectations about recovery?
Good point. It often depends on the patient, their sensation levels, maybe anxiety. You can do it under IV sedation or just local anesthetic 1% lidocaine usually without epinephrine.
And sensation varies quite a bit, doesn't it?
It does. After autologous flaps, the skin is often quite insensate. With expanders or implants, it's more variable.
Crucially, though, timing relative to other treatments.
Oh, absolutely critical. Nipple reconstruction needs to wait until after chemotherapy and radiotherapy are completely finished, no question.
And any reshaping of the breast mound itself.
Yes, wait until after any revisions, too. Otherwise, you risk the nipple ending up in an unpredictable position if the breast shape changes later.
Makes sense. But the upside is minimal downtime.
Exactly. Patients are usually reassured by that. Back to normal activities pretty much the next day.
Okay, let's talk positioning. Getting that symmetry right must be challenging. What are the core principles?
It's probably the most important part for patient satisfaction, visually. You mark with the patient standing up, shoulders relaxed.
Get them involved.
Yes,
Yeah.
definitely. Even something simple like using a sticker to let them indicate where they feel it looks best can really help. Symmetry with the other side is the goal.
And what defines that symmetry?
Several things. You want the reconstructed nipple on the same horizontal level, the same transverse plane as the opposite one.
Less critical in bilateral cases, I suppose?
A bit less critical, yes, as long as they align well together. But ideally, same plane. Then you want it centered on the breast mound itself.
Over the fullest point.
Exactly, over the point of maximal convexity. And matching the projection, the height of the contralateral nipple is vital.
And the overall look.
Yes, consider the whole picture. Base width, areolar size, even the pigmentation of the other side. You're trying to replicate it as closely as possible.
Okay, moving on to surgical techniques.
Mhm.
Local flaps seem to be a mainstay for the nipple itself. What's the basic idea?
The idea is using the adjacent tissue, rearranging it to create that nipple projection. These flaps rely on the blood supply in the skin layers, the subdermal plexus.
So you design the flap based on that blood supply.
Precisely. You can orient them in different ways, sometimes needing to work around old stars, donor sites. Well, ideally you close them, primarily.
Minimal tension.
Minimal tension is key, absolutely, to avoid whiting scars. Sometimes a small skin graft is needed. Too much tension on the reconstruction itself is bad, too.
Leads to flattening.
Yes, increased surface tension can cause loss of projection, flattening over time. If you do need a graft, it's better if it sits within the final areola pattern, makes tattooing easier later.
And that flattening,
Yeah.
it's no limitation, right?
It is. Scar contracture over time is the enemy of projection for pretty much all local flap techniques.
Could you walk us through some common flap type?
Sure. The skate flap is quite popular. It's predictable, versatile, good for matching a larger opposite nipple. It has a central dermal fat part and two wings,
In the donor site.
often closed with a small graft, or sometimes primarily if tension allows. There's also a modified skate flap,
When would you use that?
useful after skin-sparing mastectomy, especially with autogenous tissue. It lets you keep a circular skin island, avoiding an areolar graft.
Okay, what else?
The CV flap. Two V flaps give the height. The C flap sets the diameter. Donor site can often be closed directly. Maybe not great for really thin skin, though.
Any variations?
The fishtail flap is basically a modification of the CV, just with angulated V flaps. Then there's the star flap.
Five flap?
Yeah, it uses several tapered arms wrapped around a central bit. It's quite straightforward to design. Easy primary closure usually.
Downsides?
Projection might be a bit limited, and you end up with 3 small donor scars. The bell flap is another option, good if you only need minimal initial projection. It's sort of pulled out and folded over,
Oh, sure.
often with a purse string suture at the base. Then you have the modified double opposing tab flap MDOT.
MDOT.
Yeah, its long axis runs parallel to existing scars. You can make the flaps wider for better blood supply, but that might make the nipple a bit oval. Some studies suggest it holds projection better than the star flap, though.
Interesting. One more.
The S flap. That's really useful if you have a scar running right across where you want the nipple. Flap length gives projection, width gives nipple width.
Lots of options there. What about using tissue from the other nipple sharing?
That's an option, yes, but only really suitable if the patient has quite a large projecting nipple on the other side and is happy to sacrifice some of its height.
How's it done?
You can take the outer, say, 3/5 transversely, or sometimes take half longitudinally and fold the remainder down.
Advantages?
The match, color and texture-wise, is obviously excellent, and it works well even on irradiated skin.
Disadvantages must exist, though.
Oh, yes. Potential issues for the donor nipple pain, maybe loss of sensation, blocked ducts, potentially affecting future breastfeeding. It's a significant trade-off.
Okay. Shifting to the areola now. Reconstruction methods.
Tattooing is definitely the most popular technique, usually done about 3 or 4 months after the nipple reconstruction itself,
Why the wait?
to allow most of the swelling and, crucially, the initial shrinkage or flattening of the nipple reconstruction to happen first.
And the tattoo color.
You generally aim a bit darker initially because it always fades over time.
Does it work well on scars?
It can be less effective on spread scars, ones under tension. And interestingly, some have noted tattooing might be associated with a slight decrease in nipple projection later.
Alternatives to tattoo.
Skin grafts are the other main option, full-thickness grafts. You can sometimes harvest them from mastectomy scarred dog ears, though less available now with skin-sparing techniques.
Or elsewhere.
The upper inner thigh is a common donor site, but potential downsides there include donor site pain, maybe some hair growth on the graft later.
And you have to plan for graft shrinkage.
Absolutely. You design the areola slightly larger than the target size to account for the contraction that happens during healing.
And just to clarify, banking the patient's own nipple during mastectomy.
No, that's generally not recommended anymore. Too much risk of transferring cancerous cells. That practice has largely been abandoned.
Right. Now back to that issue of maintaining nipple projection. It seems like a universal challenge with local flaps.
It really is. You have to expect some flattening. Studies show it can be around 50 to 70% loss within the first couple of years.
Is it technique dependent?
Some techniques might lose more than others. The bell flap, for instance, is sometimes cited as having greater loss, but it affects all local flaps to some extent.
Why does it happen?
It's multifactorial. Tissue retraction, scar contracture, maybe not enough fat in the flap initially, perhaps suboptimal design, even just tissue memory.
When does most of the loss occur?
Mostly quite early on. The biggest drop is usually within the first 2 months post-op.
So how do we combat it?
While thinking about flap design, increasing the width of the flap base is important. Better blood supply seems correlated with better long-term projection.
So overbuild initially.
Yes, that's a very common strategy. Overcorrecting the projection at the time of surgery, aiming for maybe twice the desired final height immediately post-op is a reasonable goal.
Because it's easier to reduce than add later.
Exactly. It's much harder to regain lost projection than to trim down an overly prominent nipple later if necessary. And significant flattening is a major source of patient dissatisfaction, so it's worth trying to mitigate.
Are there specific augmentation techniques to boost or maintain projection?
Yes, you can augment the nipple reconstruction itself. Options include adding structural support with, say, fat grafting, dermal grafts, or even cartilage.
Cartilage? From where?
Auricular cartilage from the ear has shown good results, although obviously there's donor site morbidity to consider. Tissue-engineered cartilage is also being explored.
What about cellular dermal matrices?
Things like alloderm, yes. Placing a small piece strategically between the flap layers might help provide some scaffolding and improve projection longevity.
And post-op care. Anything specific for projection?
Definitely avoid any dressings that put direct pressure onto the reconstructed nipple, especially early on. That can compromise blood flow and lead to necrosis or flattening.
Speaking of which, complications. Are they common?
Thankfully, significant complications aren't that common. But when they occur, it's usually related to wound healing, partial or even total nipple necrosis.
Due to ischemia.
Primarily, yes, insufficient blood supply. It's not necessarily specific to one type of flap over another.
Does radiotherapy play a role?
It certainly increases the risk. Prior radiation makes the tissues more fragile, increasing the chances of tissue necrosis or delayed healing. Something to factor in.
Okay. One last area, flat or inverted nipples. How does that fit in?
Well, it affects up to 10% of women, either congenitally or developing later. Anatomically, it's often down to short lectivorous ducts and maybe a lack of supportive collagen structure around the base.
Is it graded?
Yes, there are classification systems for severity. Treatment principles generally involve trying to create some tightness at the nipple neck, maybe adding some bulk underneath, and sometimes releasing fibrous bands.
Does that affect function?
Releasing bands can potentially impact lactation, so that needs careful consideration. And recurrence after treatment can happen. Rates vary.
Right. So if we were to boil this down to key take-home points for residents revising this topic.
Okay. First, NAC reconstruction is essential for a truly natural-looking breast. Second, there's no single perfect technique. It's about choosing wisely for the patient.
Patient involvement helps.
Hugely, especially in positioning. Third, expect that 50–70% projection loss with most local flap techniques over time.
So overbuild.
Yes, aim for about double the desired height initially. Fourth, always perform it on stable, symmetrical breast mounds for accurate positioning.
Other key points.
Contralateral nipple grafts give a great match but have donor site consequences. The skate flap is particularly good for matching larger opposite nipples. Well-healed skin grafts take tattoo pigment better than stretched scars. And always remember, prior radiotherapy increases complication risks.
That's a fantastic summary. This has been a really thorough deep dive into nipple areolar reconstruction. Hopefully this gives everyone a solid grasp of the principles.
Understanding the nuances from the planning through to managing expectations about projection is vital.
Absolutely. Tailoring the approach to the individual patient and their specific reconstruction is key. Thanks for joining us.